Thanks so much again to everyone here today. I know there was a lot of people involved in making this happen. Thanks to you for coming out. Today I'm going to talk to you about Kidney Cancer 101 and also just about kidneys. I have no financial disclosure. This is an overview of what we're going to talk about over the next 15 minutes. It's going to be kind of a whirlwind, but you know, my plan is to talk a little bit about sort of kidney cancer diagnosis and that process, and then talk a little bit about surgical treatments at the end. So every year the American Cancer Society will release cancer statistics about U.S. cancer cases. And so this is a very sort of commonly cited diagram that you will see in the literature. And if you haven't spotted already, you can see that kidney cancer makes up about 5% of cancers diagnosed in men and about 3% in women, which is about 80,000 cases per year in the U.S. The bottom half actually shows you sort of the deadliest cancers in the U.S. And luckily, kidney cancer is not on the top 10 list. It didn't actually always used to be that way. It's you know, we've made a lot of strides over the last 20 years with therapies, especially for metastatic or stage 4 disease, and luckily kidney cancer doesn't make the top 10. Okay, so how is kidney cancer discovered? Well, most kidney cancer is actually discovered incidentally, meaning you know your doctor or healthcare provider was getting a scan for something completely unrelated, abdominal pain or back pain, and then it was found. And so you know it's because you know, most patients don't have any symptoms. But you know, I just want to kind of do a quick sidebar about you know, where are your kidneys? What are they doing? So kidneys are actually, you know, most people have two kidneys, one on either side. And most of the time they're located in front of the 11th or 12th ribs in the back. They're about 10 to 12 centimeters in length. And if that conversion is not immediately apparent, if you just spread your fingers out like a USF bowl sign, your kidney is slightly larger than that, okay? And the main job of the kidneys is to filter blood. So your kidneys will take the blood and it will remove all the metabolites and all the extra fluid and things that your body doesn't need. The kidney does other things too, which include things like maintaining your blood pressure or creating hormones to create red blood cells. But those jobs are actually shared by other organs. So the unique function of kidneys is to filter blood. And that sort of is going to be important with treatment decision making, because depending on somebody's overall kidney function, which is a reflection of how well they're filtering the blood, that's going to sort of weigh into the decision making about treatment. This secondary picture is actually sort of an internal anatomy of the kidney, and that's important when we're talking about specifically surgical treatments. So I just wanted to kind of briefly mention, you know, the internal anatomy. It's such that, you know, blood will enter the kidney in the center part, urine will be made on the outer part, and then be collected in the center part again. So the center part of the kidney, there's a lot going on, and so, you know, tumors can arise anywhere in the kidney, and when they show up in the center part of the kidney, that can kind of affect surgical treatment. Once urine is made, it will travel all the way down into the bladder. All right, so that's a little bit about kidneys, and let's talk about actually patient presentation in terms of kidney cancer. So unfortunately, there's not really any dedicated screening test for kidney cancer yet. And as I mentioned before, you know, a lot of this has to do, you know, most kidney cancers are found incidentally because patients don't have any symptoms. But that's not always the case. You know, some patients will present with blood in the urine, or flank pain, sort of pain around the side of those ribs, or if it's large enough, there can actually be a palpable mass, meaning you know, you can feel the mass underside or from the front. They also call kidney cancer the internus cancer because sometimes people can present with sort of more vague and nonspecific symptoms such as weight loss, fever, or abnormal blood work. And then rarely when tumors have metastasized to other parts of the body, you can actually get symptoms from those tumors in other parts of the body as well. So those can be things like bone pain or neurological symptoms or cough. But you know, once kidney cancer is suspected, you know, the first step is always dedicated imaging of the kidney and surrounding organs to see sort of where the kidney cancer has gone to, if it is kidney cancer. And I actually just want to sort of focus on that point for 1 second. You know, we've been talking this whole time about kidney cancer, but most people, when they're first diagnosed, are just diagnosed with a kidney mass. We don't really know what it is when you're first diagnosed. We have a good idea, but can't say for sure because cancer is a diagnosis that is made by looking at something under a microscope. So if there's no biopsy or surgical sample, then we can't say for sure that it is cancer. However, we can have a really good idea about what are the chances that something is cancer based on imaging. And actually, Dr. Thomas is going to talk about that next. So I'll leave that to her expertise. There's other things that kidney masses can be. So that can be like a benign growth or an infection or other sort of non-growth type of lesions. It can also be like a cyst, which is sort of a fluid-filled sac, which can be cancerous or non-cancerous. And so needless to say, it can get a little complicated. Sometimes when the diagnosis is in doubt or the differential is a little bit longer, biopsy can be helpful. But that's not always the case either, because it may not affect actually proceeding with some definitive treatment. So biopsy may not always be necessary, especially in early stages. So at this point, a lot of people, once they are diagnosed, they ask, how did I get this? And is it possible to pass it on to my children, for example? And for that, we look at the risk factors for kidney cancer. These are some of the most common ones. Kidney cancer is definitely one of those things that can run in families. And so it's never a bad idea to ask your doctor if there might be extra testing that might be needed to see if the kidney cancer is sort of part of a heritable condition that can be passed on to another person. Other people will also see sort of high blood pressure, obesity, and smoking and ask, if I had my blood pressure under control and I lost some weight and quit smoking, would that decrease my risk of kidney cancer? And the answer is probably yes. But also there's a lot of other good reasons to do those things. So it's always good to sort of consider new strategies to try and achieve those goals, which is obviously way easier said than done. Finally, there are some occupational exposures that can be associated with kidney cancer, usually heavy metals or sort of industrial toxins, but there are other professions that can be at risk too, like firefighters. Okay, so we've covered a lot so far. Now we can start to kind of get into the nitty-gritty about the types of kidney cancer and the staging, which tells us about the risk stratification of kidney cancer. Kidney cancer staging is very important. It tells us a lot about sort of what treatments should be pursued, which I'll talk about in a little bit, and also a little bit about prognosis. And so whenever we've got that imaging, which is all a lot of the information that we need for staging, our first question is, has the kidney cancer spread outside of the kidney into distant organs? We usually call that a distant or stage 4 type of cancer. And if not, what is if it's confined to the kidney, what is sort of the size of the tumor, the primary tumor in the kidney, and also which structures immediately adjacent to the kidney or right next to the kidney does the tumor involve. The stage 1 and 2 are primarily determined by size and the absence of invasion to surrounding structures. Whereas stage 3 usually involves some surrounding structures, and stage 4, you can still have a tumor that's confined to the kidney, but sometimes when it grows outside of the fat or into an adjacent organ, that is considered to be stage 4. And so really, a lot of that, it sort of goes back to this original picture of the internal anatomy of the kidney, where, if some of these structures are involved, then it may be, a stage 3 or higher type. There are, the other important aspect of risk stratification is talking about kidney cancer types. There's a lot of different ways to sort of classify kidney cancers nowadays. There's actually a recent release of a very long classification system by the WHO in 2022. But one thing has not changed, which is that most diagnoses of kidney cancer are still what we consider to be renal cell carcinoma, or RCC. And most RCC is what we call a subtype called clear cell RCC. Clear cell RCC is named because of the appearance of what it looks like under the microscope. This is a representative image of a clear cell RCC. The cells there are sort of clear in appearance compared to other types of cells. There are other subtypes of RCC, such as papillary and chromophobe, and then there's also other very rare types that are determined sort of by the sort of underlying molecular biology of kidney cancer. So, like I said, this classification scheme can get really complicated, But it's actually a reflection of our very, very good understanding now of the molecular biology of kidney cancer, which has really been sort of a long process starting in the 90s that has gotten very refined in the current era. Okay, so once we've talked about risk stratification, staging, the type, the imaging, and all these factors, we can start to talk about sort of what is the treatment paradigm. And I like to talk about it in terms of a paradigm because it's not really a rigid framework at all. And most situations are going to have a lot of nuances that are not going to perfectly fit into this paradigm. But this at least gives us a way of thinking about kidney cancer treatment from sort of a 50,000 foot level. So in the first bullet point, we talk about kidney cancer that is confined to the kidney. In that situation, some treatment options can be active surveillance ablation or even radiation for early stage, like stage 1. But really surgery is kind of the sort of gold standard of care that we compare everything to. So that's why it's underlined here. And we can do that for all sorts of stages that are confined to the kidney. Sometimes after surgery, folks will also now be receiving some sort of adjuvant systemic therapy, which is usually an immunotherapy. In the second point, we talk about kidney cancer that has spread to other organs. And in that situation, usually we get a biopsy first to confirm what the kidney cancer type is. And then somebody will go on to receive some type of systemic therapy, which is usually the backbone of treatment. And that usually includes targeted treatments or immunotherapies, but pretty much never chemotherapy. There are some rare types of kidney cancer that can respond to chemotherapy, but most systemic therapy for kidney cancer is immunotherapy and chemotherapy. And we do have some medical oncologists speaking today about some systemic therapies. Okay, so that, again, 50,000 foot level, that's sort of the treatment paradigm, okay? All right, so now, in the brief time that I have left, I want to talk a little bit about surgical treatments. There's a lot of people speaking today, but because I'm a surgeon, I just kind of want to talk briefly about what does surgery entail and when do we do it and what's the gist of it. There are two main surgeries that we do for kidney cancer, partial nephrectomy and radical nephrectomy. Partial nephrectomy is where we remove just the tumor and a rim of normal tissue, and we leave most of the kidney in place. Radical nephrectomy is where we remove the entire kidney itself. A lot of the times we can actually do either one of these surgeries minimally invasively. So that can be robotically or laparoscopically, but that's with smaller incisions, and I can talk a little bit about the benefits of that. And then there's other sort of rarer situations where we might do some sort of complex surgery which may involve a radical nephrectomy. Or removal of kidney cancer that has spread to some distant organs, but I'll come back to both of those in a second. So first, what is a partial nephrectomy? Like I said, you remove the tumor and a rim of normal tissue, and then you have to reconstruct the kidney, put the kidney back together again. This is actually, more complicated of a surgery to do than just removing the entire kidney because of that reconstruction part. Why would you do that? Well, the pro is that you get to save more kidney. The more kidney tissue you can save, that's going to be better for your kidney function. And so, again, it kind of goes back to, what is that baseline kidney function? For those who sort of go in with a lower than normal kidney function, saving kidney tissue might be a very big priority. The cons of doing it, as I mentioned before, it's more complicated. So the complication risk is actually a little bit higher. There's a lot of tumor and patient-specific factors that play into whether or not your surgeon might recommend one versus the other, but also patient preference. So this is, me and Dr. Manley talk about this in our office all the time. As I mentioned before, robotic and minimally invasive surgery is definitely an option for a lot of different people. Both myself and Dr. Manley do this. The advantages really are that the incisions are smaller, the recovery is faster, there can be less blood loss, and the pain is lower. But in terms of those long-term cancer outcomes, sort of like survival and recurrence and all these things that are related to longer-term things, those outcomes are fairly similar between the two, and also complication risks. So, sometimes minimally invasive surgery is just not feasible. So if it's not feasible and the surgeon is recommending open surgery, that doesn't necessarily mean it's the wrong thing to do just because there's these, advantages to minimally invasive surgery. You want to do what is the safest, way to do what needs to be done. As I mentioned before, there are some situations that sort of increase the complexity of surgery, and specifically, when there's larger tumors or tumors involving surrounding structures. And the only thing I'll say about this is that really sort of high volume medical centers are usually the best place to, one, get an opinion about this, and two, potentially get the procedure done, as we know complications to be lower at these places compared to places that don't do it as much. We're talking about situations in which the tumor might be involving the vena cava, which is a large vein in the middle of the body, or other surrounding organs. And then finally, there are some situations in which surgery can be done in kidney cancer that is spread to other organs that are beyond the kidney, such as the pancreas or lungs or the adrenal gland. But this is really more the exception than the rule, because we only do it for situations where there's limited disease, and the goal of therapy in this situation usually is to pause systemic therapy for an unknown amount of time. So it's not typically done with curative intent, so to speak. But I'll just leave it at that. Again, high volume centers, places that do a lot of this surgery, are the best place to get an opinion and then potentially get a procedure.